Thank you. Well, it's a pleasure to be able to talk today, and thanks for the invitation. I'm Professor Tony Cleare. I am a professor of psychopharmacology and affective disorders. I have a particular interest in treatment-resistant depression and the pharmacological treatments thereof. As Becky presented earlier, we do have a specialist unit that treats patients with difficult-to-treat treatment-resistant conditions, both unipolar and bipolar. And today, I really am focusing on, the pharmacological management of treatment-resistant depression. How can we optimize what we've got? And I'm also going to talk a little bit about some new data. So just to start with my disclosures, which you'll see here in terms of treatments, I am talking about a few of the treatments that I provide some advice on. So those are the disclosures. So really, I'm going to talk a little bit about how do we optimize the antidepressants we have. We've talked about, lots of different choices, but I think we can be a little bit clever sometimes with how we optimize the actual antidepressant we use. I'm going to move on to really focus on where we are with these augmentation and add-on strategies. I'm going to present, in the middle part of the talk, quite a lot of data from the LQD study. Becky started talking about this. This is a recently finished large study comparing different augmentation treatments. And if I have time at the end, I'll just talk a little bit about where the research is going and what might be next. So I talked a bit about antidepressants. Can we be a little bit clever with how we choose an antidepressant? If you like, can we maximize the response we get so fewer patients go into the next stage treatments that I'll be talking about later? So Hamish has already talked a little bit about this, so I'm not going to go into too much detail about it. Just to pick out a few points that I think are of interest. I mean, I do think we can and should be thinking about whether we can treat the frequent comorbidity we see in depression with our choice of antidepressant. The classic example, of course, is the patient with comorbid depression and OCD. We know that OCD responds to a serotonergic antidepressant, so we should really be focusing on the strongly serotonergic antidepressants. Similarly, anxiety, we know that some antidepressants are more effective against anxiety than others, and so we should be mindful of that. Symptom-specific benefits, sometimes it's not so much about improving a symptom as not making a symptom worse. So if you've got a patient who has trouble with their weight or oversleeping, giving them something that makes them put on weight or sleep even more is not going to be helpful. Sometimes we can also say, well, look, in the short term, before your depression gets better, if we give you something that helps with your poor sleep or your low appetite, that also might speed up your recovery. And then there's a number of other things which we, of course, have to take account of: patient preference, the side effects, medical comorbidity, risk of overdose, etc. And it might be in the future that we can use pharmacogenetics. I don't think that that's ready yet, certainly for services like the UK National Health Service. And then, as well as making sure that we've optimized our antidepressant treatment, again, Hamish has talked a bit about this, and I think this approach is very similar to what he talked about with the difficult to treat depression. It's really making sure that we've got a truly resistant patient, if you like, when we're looking at the pharmacology. We've done everything to assess all of the other reasons why someone may not respond well to therapy. So we've, making sure we've got the comorbidity, making sure someone's taking the treatment, making sure the treatment's given in the right dose for long enough. I particularly want to point out what's been called paradigm failures. So sometimes we may miss the particular type of depression that someone is presenting with. So a couple of classic examples. One would be a psychotic depression. Sometimes the psychotic symptoms may not be so florid. They might be a little bit hidden with the depressive delusions or quasi-psychotic features. And in those cases, I think co-treatment with an antidepressant and an antipsychotic has a better outcome. Bipolar depression, we've already touched upon. If we miss that, which can be easy to do, we might be treating people with a unipolar paradigm, whereas a bipolar paradigm with mood stabilizers as well as antidepressants could be preferable. And some evidence that atypical depression may respond differentially to certain types of antidepressants. Preferential response to older monoamine oxidase inhibitors over tricyclics, for example. And then obviously again, Hamish just talked about this, the other things we can do to try and make sure that we're sort of covering all the other factors that are impacting on the illness. So having done all that, we get to the stage where we have to make a decision in these patients who, despite all that, haven't responded to their first or second antidepressants. What are the options we have? Broadly speaking, we have three options. We covered this in the British Association for Psychopharmacology guidelines, which I led with many others as well, including Hamish and other psychopharmacologists from the UK and Europe. And really, we've got three options: increasing the dose, switching antidepressants, or augmenting antidepressants. So what's the evidence for each of those, and how do they compare? Well, the first thing to say is that the one that's most commonly done is a dose increase. And unfortunately, it's the one which has probably got the poorest evidence base of all, particularly with SSRIs, which are, of course, the most commonly used antidepressants. There are very few good studies which have done a proper placebo-controlled, double-blind, randomized comparison of an increased dose versus continued dose. In fact, some of the ones that have been done have showed that the increased dose may lead to a worse outcome. One exception to that is probably escitalopram, where there is some evidence that a 20 milligram dose is better than a 10 milligram dose. But even so, although it's something we often do, and although we do see some patients who just seem to do better on higher doses of antidepressants, it isn't a well evidence-based option. Now, for some antidepressants like tricyclics, venlafaxine, vortioxetine, there's a much clearer dose response. So I think we're on better grounds when we do it with those treatments. So the second option I said was was an antidepressant switch. Now, this is a better evidenced strategy. There's quite a lot of studies showing that an antidepressant switch is effective, although, of course, the more times you switch, as we saw from the STAR-D study, the less the response is. One of the questions that we often have to think about is, should we switch from an SSRI to another SSRI, or should we try a different class of antidepressant? And of the studies that have been done, this was a meta-analysis suggesting that, in fact, if you try a different class of antidepressant, you do have a slightly higher response rate than if you go to a second SSRI. So that's some evidence in favor of a between-class switch in using that strategy. When we looked at the evidence of whether some antidepressants may have slightly increased efficacy over others in the BAP, we did find some evidence for these 6 antidepressants. Again, it's a sort of variable level of quality, but we felt that if you were desperate for the sort of most efficacious antidepressants, these are the ones where there is probably some evidence of a bit of an advantage over the others. Of course, we've also had some recent network meta-analyses which give comparisons of all of the antidepressants in some sort of order. But although it gives us some indications, I think we should be wary of having some sort of league table that antidepressant A is definitely better than antidepressant B, because there are so many other variables involved. So the next question is the augmentation strategy. How does augmentation as a strategy compare to switching? I would say probably augmentation is the third most commonly used. People will usually try a dose increase and a switch before they go to augmentation. How does it compare? Well, this was a large study called the VAST-D, which looked what happened after you'd failed your first antidepressant, that you'd had a non-response to the first antidepressant treatment. And this compared 3 arms: a switch to a different antidepressant. In this situation, it was bupropion, augmenting with bupropion, so adding that to the existing antidepressant, or augmenting with aripiprazole. To cut a long story short, the most effective strategy that was clinically significant and statistically significant was the augmentation with aripiprazole. So, again, there's not a lot of evidence, there's not a lot of studies, and this is a relatively short-term study over 90 days. But there is some evidence that augmentation is an effective strategy that might have some advantages over switching antidepressants. In the BAP, we went through all the different evidence to try and say, can we work out which might be the most effective or the most evidence-based augmentation options? what we came up with, this is going back about 5, 6, 7 years. So, this is the state of the evidence at the time. We felt that the first line, level 1, best quality of evidence supported lithium, quetiapine, and aripiprazole. There was decent evidence for risperidone, olanzapine, mirtazapine, thyroid hormone, bupropion, and buspirone as add-on treatments. And then a number of, less common options that we often find ourselves using in the specialist tertiary units, but with very variable amounts of evidence. The Maudsley guidelines is a bit more recent, recently updated, and has added some few additional options, including ketamine, esketamine, and also lamotrigine, mirtazapine, bupropion, and olanzapine as sort of slightly higher level of evidence than we had. And, although I'm focusing on pharmacological options, I always want us to remember that we should not be forgetting the other options we have. Psychological therapy in particular, we must always be thinking of adding it into our treatments, but also there are these other options that that we can consider at different points in the pathway. So Becky touched on this earlier about the different guidelines. And one of the problems we have is that the guidelines have a somewhat different viewpoint as to when we might best consider augmentation. So we looked at 10 of the most commonly used guidelines, including NICE, BAP, American Psychiatric Association, etc. And what you can see is that there's a difference, firstly, in how many treatment trials you can think about before using augmentation. Should it be 1 failed trial, 2 failed trials, three failed trials, and how long each trial should be? Is it 2 weeks? Is it 4 weeks? Is it 12 weeks? So there's not a consensus in the literature about that. And there's also not a consensus. This was another study when we looked at which augmentation would be preferred. There's not a consensus as to which are first line and which are second line. Generally speaking, antipsychotics, atypical antipsychotics, lithium, and thyroid hormones are all up there, but there's a difference in emphasis as to when they might be recommended. There is some evidence to try and help us make these decisions, though. I want to say the evidence is limited, and that's the sort of sad reflection of where we are. There's a limited amount of evidence as to which augmentations might be more effective. This was a network meta-analysis that looked at all of the augmentation treatments. And, if you know about network meta-analysis, you know that because there aren't many head-to-head comparisons, we can build up a network of indirect comparisons to try and build up a comparative efficacy of the different treatments. By and large, almost all the studies have been against placebo, with very few head-to-head studies. Even so, this was a network meta-analysis that tried to put all that together, and it came up with this overall summary of the evidence back in 2015 again. So what we have is the most efficacious treatments are up here on the top left of the slide. So when you put them in order, quetiapine, aripiprazole, lithium, and thyroid hormone come out as the most efficacious. If you remember the BAP guidelines, I said quetiapine, aripiprazole, and lithium were the ones that we felt had the strongest evidence, and that's borne out by this network meta-analysis. But also thyroid hormone comes out quite well. If you look down here at the bottom right part of the graph, you can see tolerability, and unfortunately, the same treatments that are the most efficacious are the least well tolerated. So we have quetiapine, we have lithium, we have aripiprazole, and a few others. So unfortunately, our most efficacious treatments are the ones that come with the most, the least tolerability, the most problems with side effects. Interestingly, thyroid hormone is actually very well tolerated. So, I think thyroid hormone is one of those treatments which has become a bit overlooked. It's probably not used as much as it might be, but the evidence, insofar as we have limited evidence, as I caveated at the beginning, the evidence is suggestive that perhaps thyroid hormone is a little bit underused. And I just want to reinforce that point about the lack of head-to-head studies. This was a more recent systematic review and meta-analysis that looked at all of the head-to-head studies that have been done in treatment-resistant depression of augmentation. And what you can see is really there's only 8 or 9 studies that have ever been done directly comparing two treatments, not against placebo, against each other. And of those, they've all been short term, between 6 weeks, or a couple of them have gone up to 12 weeks. They've also, by and large, been small studies. There's only been one study really that's been over 200 people, and that was a subset of TRD, sorry, 2 studies, another one as well, a short-term study of lithium versus quetiapine. So this is really an introduction to say, because of this poor state of the evidence, we wanted to do a good comparison of 2 of the first-line treatments for TRD. So we designed the LQD study, lithium quetiapine for depression study, which was a randomized pragmatic trial which was comparing the clinical and cost effectiveness of lithium and quetiapine. Importantly, as well as doing a head-to-head comparison, we wanted to make it in clearly defined treatment-resistant depression, as in a failure of 2 antidepressants, and over the long term. So this was a 1-year study with a 52-week follow-up. We also wanted to take frequent measures of outcome. Because we know TRD is a longitudinal condition, people might get a bit better, a bit worse, relapsing, remitting. We didn't just want to say, what's the outcome at 52 weeks, because that misses so much. So we took weekly ratings of people over a year to try and understand how well they were doing. Just to summarize, it was a DSM-5 depression, not psychotic, not bipolar, because as I said, that may be a different treatment paradigm. Moderately depressed, at least a Hamilton score of 14, the same as TRD. 2 failed antidepressant treatments on a stable dose of antidepressant, not had a trial already of lithium or quetiapine. So I'm going to spend 5 minutes or so presenting the results of this study. First thing to say is we managed to recruit and randomize 212 patients, which was our 80% power target. And this was the treatment allocation. Our intention to treat sample is these 212. Because when you start these 2 treatments, not everyone gets prescribed them because of the screening. We also had a per protocol sample of people who actually started taking the medication. And then we had the 52-week follow-up. I'm not going to spend too much time on these slides other than say that it was an average age in the 40s. It was a slight preponderance of females, as we might expect, and it was a moderately depressed group. Mean Hamilton score was 21, mean MADRS score was 30. Okay, so this is the results that we've got. So the first primary outcome we had were these weekly clinical ratings of depression. Patients provided a QIDS, the Quick Inventory of Depressive Symptoms rating, every week over 52 weeks. And what we have is, I've got the raw results here and then the sort of modeled results. We had a clear advantage for quetiapine over lithium over the course of the 52 weeks. As you can see, it was a sort of, both groups showed an improvement over time, but the improvement was larger in the group taking quetiapine. This was the intention to treat analysis. As I said, in the per protocol analysis, those who took the treatments, there was a similar result as well, with an advantage for quetiapine over lithium. The statistical significance is here. It was at the p 0.02 ratio. We took an area, let's go back, we took an area under the curve for the whole 52 weeks, showing that the benefit was maintained over the whole of that 52-week period. You can see variability. People do go up and down, and that's classic. That's what we expect to see in treatment-resistant depression. We had a second primary outcome, which was how long people kept taking the treatment. This one wasn't significant, but it was in the same direction. So in red, you have people staying on lithium. In blue, you have people staying on quetiapine in both attention to treat and per protocol. More people stayed on quetiapine than lithium in both analyses, but it wasn't a significant difference. We had some secondary analyses too, not much difference at 8 weeks, not surprising, but at 52 weeks, we did find a benefit in the secondary outcome for the MADRS score and the work and social adjustment score. As I said, I'm not that keen on just a cross-sectional 52-week analysis, but it was in the same direction. If we look at we also took the work and social adjustment scale every week to look at function over the 52 weeks, and we found a very similar impact, a benefit of quetiapine over lithium in function as well, similar to the one we'd seen on symptoms. Side effects, no difference between groups. We measured really the severe adverse effects, very few, and very few that were related to drug, no difference. Weight was no difference between groups, and the number of physical symptoms, side effects described was no different. So there was no difference in tolerability that we could detect using the standardized measures. One thing we thought to ourselves was, hold on, lithium is a bit tricky to give. What about people who only took a therapeutic dose? Not everyone got up to the recommended 0.6 millimoles per liter level. And we did a sensitivity analysis only in those who had a good level of blood lithium against only those who got up to 150 milligrams of quetiapine. And again, similar result held that remained significant and advantage for quetiapine. So it wasn't just that the lithium was given poorly. It was a difference even in those who got properly given lithium. And finally, cost-benefit analysis, health economic analysis. What did we find? Well, our primary outcome was the cost to the NHS, and quetiapine was cheaper to the NHS overall when we looked at all of the costs over 52 weeks. If we looked at societal costs, there was a slight benefit for lithium, although there was still a 44% chance that quetiapine was cost-saving. But the important thing was that was just the overall cost. When we looked at a QALYs analysis, so the cost per quality adjusted life year, quetiapine had a benefit in QALYs. So basically, quetiapine was 99.5% likely to be cost effective on a QALYs health economic analysis. So the conclusions really from the LQD study are that in this group of people, quetiapine was clinically more effective insofar as there was a reduced symptomatic score maintained over 52 weeks. There was a reduced functional impairment, and there was a similar level of adverse events. It was more cost effective. This is real world data. This is people prescribed as they would be in the clinic, and it's a long-term outcome. It raises the question, should quetiapine become the sort of standard first-line treatment of choice for augmentation in treatment-resistant depression? And you might argue, well, this is very powerful evidence of quetiapine at least should be considered as a first-line treatment, but I wouldn't throw lithium away, too quickly. Let's just look at some other evidence for lithium. The first thing to say about lithium is suicide. We know, I think, quite convincingly, particularly in bipolar disorder, but also with some evidence in unipolar disorder, that rates of suicidal acts and completed suicides are lower in long-term use with lithium than with other similar mood stabilizers. So I think in patients where we're concerned about long-term risk of suicide, we need to factor that in when thinking about whether to use lithium. The other thing is recurrence. We know that lithium really is good at preventing recurrence. This is a very powerful study from Finland that looks at readmission to hospital for people with unipolar depression using their very comprehensive database, all of the treatments. And down here, you can see that the best evidence for reduction of readmission comes for people who are maintained on lithium. It's not to say that other treatments aren't effective too, but we can't ignore that lithium has very powerful relapse prevention properties. So people with highly recurrent illness, lithium is a very strongly indicated treatment. I can't finish the comparison without talking about the recently published ESCAPE study. So ESCAPE was published about 3 weeks ago in the New England Journal of Medicine, which looked at esketamine compared to quetiapine. Similar dose of quetiapine to that we use, 150 to 300 milligrams. Esketamine given twice a week for 4 weeks, once a week for another 4 weeks, and then once or twice, once or a week or once per fortnight over 32 weeks, as is standard. This study found some benefits in esketamine compared to quetiapine. And I think, again, it's an open label real world study. What I would say, again, you might say, well, hold on, that means esketamine is even better than quetiapine. Well, in this study, yes, the response was better. The problem is I don't think esketamine is given in the same way as quetiapine. Esketamine, if you like, is a complex intervention where you are coming to hospital twice a week, you are getting input from someone, you are getting time, you are being looked after for 2 hours at a time. It's a different type of intervention, which I think has its own added benefits over and above the pharmacological effects. If someone having quetiapine had to come in twice a week to get a new treatment where they had to be looked after and monitored carefully, we might not see quite such differences. But even so, I think it's powerful evidence that esketamine is also an option that we can think about for augmentation. Now, I'm coming to the end of my time, so I'm not going to spend too much time. Just to finish off for a couple of slides. Pragmatically, when do we augment? I mean, I would say there isn't a hard and fast guidance. There's no clear indication to say when you should or you shouldn't. But pragmatically, if someone's shown a partial response to antidepressants and they're tolerating their treatment, that might be a good indication to add treatment on rather than switch treatment. Previous history, if there are some indications in the clinical diagnosis, psychosis, or bipolarity, and any other factors, as I've already said. So a pragmatic decision when to use augmentation, but there's no doubt, as Becky showed, it's underused. What are the future? I mean, I'll just perhaps summarize and leave it with this slide. Where are things going? I think I've talked about ketamine and where that might go, and of course there may be son or daughter of ketamine down the line. Anti-inflammatories, there's a clear indication that some patients with treatment-resistant depression have an increased inflammation, and maybe an anti-inflammatory strategy might be an add-on we can think about in the future. Probiotics, we've recently looked at the addition of probiotics to antidepressants, and that does seem to have an effect. And I think this is an area of research that will grow. Dopaminergic treatments have been under-researched. We focus on serotonin and noradrenaline. We're currently looking at pramipexole as an option, and we'll have some results from the PAX-D study in a year or two. Psychedelics, we used to think was an alternative to antidepressants. There's been some recent studies suggesting that we can use them as add-on treatments as well. So I suspect we'll be hearing more about that in the future. And then various other nutraceuticals, methylfolate, SAMe, other sorts of things that maybe some particular patients may have an interest in. But I'll leave it there, and thank you very much for your attention.